with the series of the breast which we had. If you remember, I covered the management of axilla and the recent advances. Then Dr. DG Vijay covered LABC. Now I'm going to cover what is the role of neoadjuvant therapy for what a surgeon should know as a surgeon perspective in an operable breast cancer. Remember, this is not LABC in an operable breast cancer because maximum advances actually happened in the field of operable early breast cancer with neoadjuvant treatment. As you understand this, the concept for various surgical aspects for a surgical oncology students are very clear. So today I'm going to cover the neoadjuvant therapy in breast cancer, what we need to do on surgeon perspective. Hopefully later I will also request my colleague, either I think Dr. Neeta, or one of my colleague from Tata to cover on what is the role of surgery in stage 4 metastatic breast cancer. So that would sort of, complete the spectrum and gamut, and later let me call a medical oncologist to cover what is new in medical oncology part of breast cancer. So that would cover all these 5 lecture series would cover everything about breast. Then we can have some case discussion because we had a discussion of LABC recently. We'll have one early breast cancer discussion, case presentation, and some journal club. Sort of that would very well clear everything about the breast cancer. So what I'm going to do now is I will let you know, even though all of them are operable, even though at presentation breast conservation is possible, why should we give neoadjuvant treatment in a operable early breast cancer even if breast conservation is amenable? So how should we select the patients? What is the workup in MDT we need to do? What type of therapies we should select? And what is the surgical management of axilla in this scenario where neoadjuvant treatment is given? Should sentinel node be done before? Should be done after? Should we do clipping? If the node is positive, does it always mean ALND? And then based on the response to the neoadjuvant, do we change the surgical management? At the outset, it's very important to understand for a surgeon, depending on the type of surgery you do, type of surgery and the margin. Currently, the biological classification of the breast cancer, luminal A, B, TNBC, basiloid, variety, or HER2/neu has no impact. What I meant is the type of surgery. Multimodality treatment will vary. Anti-HER2/neu therapy is given before surgery in HER2 positive. Triple negative patient more than 2 centimeter, even though they are operable, even though breast conservation is possible, should undergo neoadjuvant therapy to assess the response as per the createx trial. HER2/neu should also undergo neoadjuvant therapy if it is 2 centimeter and above. Luminal A should have neoadjuvant hormone therapy if it is not amenable for breast conservation and wait for 6 months and then do. But per se, the type of surgery, mastectomy or breast conservation, margin how much to take, is currently, as of today, is not based on whether it is luminal A, B, TNBC, or whether it is HER2/neu positive. So the type of surgery and the margin doesn't change. That's very important to understand. The approach sequencing may change, but not the surgery per se. So now remember, most of the people think neoadjuvant therapy means downsize. Don't use the term downstage. Even though in TNM we have YTNM. Y means it may be a T3N1M0, stage 3A, operable LABC. But after you give neoadjuvant treatment, it may completely go off. It may become T1N0M0 now, which we put a small y. I already covered the TNM and AJCC class for you. So you know that during multimodality treatment, you put a small y, that means during multimodality. But still remember, the first stage before the start of multimodality treatment and neoadjuvant is what determines the outcome for the patient. So as a surgical onco student, better you say you downsize, you don't downstage, even though you can put a YTNM. So it doesn't just mean that neoadjuvant treatment is for downsizing only. Now, traditionally, if you see centigallons, those people who practice breast, you must understand 2 important congress you must attend, follow the guideline. One is a centigallon congress. This is for EBC, early breast cancer only, covers only early breast cancer. Then SABC, San Antonio Breast Cancer Congress. This is surgical, medical, radiation, basic research, translational research, advanced research for the breast. So these are the 2 congresses you try to should follow to get what is up to date in breast cancer. So if you look back currently, this is an era of de-escalation. Mastectomy has become breast conservation. More than 1 centimeter margin has become no ink at the margin. All ALNTs have become sentinel lymph node. Even in selected group where Z11, IBCSG 23-1 apply, SLNB positive doesn't automatically mean ALNT. So surgeon has de-escalated. Now medical oncologist, luminal A, even though it may be 1 to 2 node positive, we don't give chemo, we try to use hormone therapy. And then, we have de-escalated from anthracycline to taxanes only in some patients. And radiation oncologists are de-escalated from intramammary supraclavicular RT to the infield RT, from conventional 5-week 5040 centigrade into hyperfractionated. They also de-escalated to fast forward, fast rapid 2 weeks and 7 to 10 days. So there is a de-escalation that has happened in all the field. So if you have a low risk of recurrence, remember there is a rule, Abeloff rule. If you read like how we read Devita, there is a Abeloff textbook of medical onco, beautiful book. Please read it. When I was a surgical onco student and trainee, I read this Abeloff completely along with Devita. It gives a rule in a breast cancer. If the chance of systemic recurrence is 10% at the end of 10 years, in 10% of population, then there is a need for systemic therapy. That's the Abeloff rule. So now if the risk is less than 20%, then you just use a hormone therapy. If the risk is more than 20, less than 55, then you can decide whether it is postmenopausal, luminal A, you want to use a neoadjuvant hormone therapy, or you want to use chemo. All high risk, where the risk factor is more than 25%, you use a neoadjuvant chemo with or without anti-HER2 therapy. Then look at clinical CR and pathological CR. Remember, clinically no lump palpable. Mammography, ultrasound, MRI, breast, no lump palpable doesn't automatically mean pathological complete response. Clinical complete response usually is only 30% pathological complete response when you operate. But if it is a HER2 positive, if you use dual anti-HER2 therapy, pertuzumab and trastuzumab, then the pathological complete response may be as high as 69 to 70%. But clinical CR doesn't mean automatically pathological CR. That's why we clip the tumor, and when you excise 1 centimeter around the clip and send to histopathology, more than 1/3 or sometime as high as 70%, there is a microscopic tumor left behind, which we call ghostectomy surgery. Nothing is seen, nothing is felt, but image guided around the clip, where we do a specimen mammogram and remove it. That's why it is important to understand. You have to excise that area to prove it is pathological complete response, and also do a sentinel node at the clipped node to prove that even in the node there is no disease. So this is the algorithm which happens. Then we decide after surgery, do we need to give more chemo or not? 6 more months of oral capecitabine to be given as per Createx if it is triple negative, if there is still viable tumor or not. And if it was anti-HER2 therapy given in a HER2 positive, should we continue trastuzumab alone, or we use a ADA inhibitor, and that is TDM1. Okay, so these are the things you must understand. Now, traditionally, when I was a student, when we started doing residency, we always thought that whether you give neoadjuvant chemo or after surgery adjuvant, as long as the prescribed treatment, surgery, chemo, hormone, radiation is done in a patient in some manner, changing the sequence will not have an impact on the overall survival. Means neoadjuvant chemo will not give better overall survival than adjuvant in an operable breast cancer. So that's why only if it is an inoperable tumor, we used to give neoadjuvant chemo. Or if breast conservation is not amenable, it's a very big tumor, 5 centimeter for the breast tumor ratio, we used to give to downsize so we can make it amenable. But now there are 2 trials, Createx trial, Catherine trial, which has showed that, giving neoadjuvant chemo in anti-HER2 and HER2 positive and triple negative, and then basing further adjuvant treatment based on the response has a overall survival. That's why. Otherwise, no overall survival benefit by giving neoadjuvant, as long as you give a prescribed chemo before or after. But what is important is whether you give neoadjuvant or adjuvant, DFS, OS, everything is exactly the same, proved by all the trials. I put all the trials here, various. So you don't harm the patient by delaying the surgery by giving chemo. Don't have to be apprehensive. Oh, the chemo nowadays goes to 6 months. I'm operating after 6 months. Most of the patients are afraid, but there is no compromise in this, which is very important. Now, what are the surgical benefit of neoadjuvant chemo? As a trainee, please remember this when they ask this. Number one, by giving neoadjuvant chemo with or without anti-HER2 therapy, if they are HER2 positive, 40% of the time you can increase the breast conservative therapy. If you straight away operate all the breast cancer based on the tumor size and the breast ratio, then you are not able to preserve all the breast. But if you give neoadjuvant, because of the shrinkage, 40% of the time. So this is first thing. Second, even if you have a positive axilla before, by giving chemo, 60% of axilla is becomes sterile. So everybody, you don't have to do blanket AL and D. If it's a low axillary burden, the talk I gave last time, and if you clip the axilla and that has achieved a pathological CR on sentinel node, you can omit axilla in 40%. Second, when you do a breast conservation, we know the most important factor is maintaining a good cosmetic outcome based on the tumor and breast ratio. And second most important thing is margin should be negative. That's why some people do frozen section, some don't do frozen section. It's very expensive. Everybody may not have facility. It is not mandatory to do frozen section breast conservation, but if you have it, please do it. Then margin positivity rate finally and revisiting, taking the patient back for surgery, which is usually 10%. If you see NHS data, 10 to 12% of the time, you take the patient back to the OT after doing a breast conservation because of close margin or positive margin. That can be brought down to as less as 1 to 2% if we have frozen, but it's very expensive. So, if you give neoadjuvant treatment, since the tumor shrinks and 60 to 70% pathological complete response happen, then there is no question of margin coming positive later. So, reoperation rate comes down. So, three things. Now, what is the neoadjuvant? How does it help? 40% increase the breast conservation rate, 40% reduces the unnecessary axillary dissection in all, 60% it reduces the reoperation rate. Does we reduce the extent of surgery after NST? This question is always asked by student. Sir, we gave chemo when we plan to operate. Should we look at the what is left behind after chemo margin or prior? Remember, in oral cancer as of today, squamous CA, whether you give neoadjuvant chemo or not, the margin of excision is what was before, not what is left behind. That is why in head and neck oral cancer, people are little apprehensive giving neoadjuvant chemo, since the extent of surgery doesn't change, extent of local recurrence doesn't change. What is the use of giving chemo, and overall survival is not proved by any RCTs. Things are changing now, but in breast cancer, in rectal cancer, for sphincter preservation, what do you excise is what is left after. Like there are two MSKCC trial where if a tumor of the mid rectum and low is very close to dentate line, but sphincter per se is free. Normally, you know that in rectal cancer, distal margin has to be 2 centimeter, even well to moderately differentiated. 2 plus 3 centimeter, 3 centimeter extra mesorectum if it is a poorly differentiated tumor. But it is now accepted that if you are given a neoadjuvant chemo radiation, TNT protocol or conventional chemotherapy in rectal cancer, the margin can be as limited as 2 millimeter and you can still do a safe rectal sphincter preserving surgery. So in rectal cancer and in breast cancer, the margin and the extent of surgery is based on what is left after neoadjuvant, not what is before, unlike oral cancer. Okay, so this is in breast, which means it reduces the extent of surgery. Remember this. Okay, now what are the oncological benefits? See, remember, these are benefit for surgeon. In exam, if somebody asks NACT in breast, you have to enumerate all this. Oncological benefits of the patient compared to the adjuvant means you give neoadjuvant treatment, then you have a adjuvant treatment. So now you know your one is oncologically, if you give chemo before, if it responds, complete pathological response, partial, remember partial response means more than 50% reduction. More than 50% reduction is partial. Don't think partial is 10 to 20. Complete is full disappearance. Clinical, pathologically proved disappearance of the tumor is pathological complete response, PCR. So partial response means more than 50% regression to the p-value at the end of 3 cycles at least. Maximum response comes at the end of 3, but the response is achieved by 2. So by second, if it is not responded, unlikely it responds. Maximum response achieves at 3. Beyond that, hardly main incremental response is there. That's why every cycle you have to clinically examine, ultrasound you have to do, calipers you have to use, and at the end of 2, if there is no response, you have to change the plan. But at the end of 3, you plan to decide what is maximum at that moment. Can breast conservation be achieved? So you can know what is the response available. If there is any response less than 50%, then it is meant as no response, not partial, no response. Progression, stable disease is same as it is, progression is it increases. Now, what are the oncological benefits? One is the response, so outcome. PCR patient has the highest cure rate. Next is you can know to access to the more modern effective drug. How? If it is triple negative, you have no complete response at the end of neoadjuvant treatment. Adding oral capecitabine is useful. Or if you are given trastuzumab, you can stop trastuzumab if there is no complete response or a RCB score 01, then you can switch over to TDM1 drug. So that's a more new drug, you can use that. And nowadays immunotherapy has come in breast. Then we also have CDK inhibitor, hormone therapy, palbociclib or abemaciclib that can be used. So modern drugs are there based on the benefit and response. Then finding a residual disease, we call that RCB, residual cancer burden, you can tailor make the adjuvant treatment. So the local therapy endpoints is also met, and also you have lot of studies. So this is surgical benefit, this is oncological benefit. So the 6 points you must know when you write to the when you answer in the exam or write in theory. Now we will take the first concept, breast conservation. We all know that breast conservation or mastectomy in eligible patient, not inferior, both are same. Nowadays the trend is showing breast conservation with when radiation probably has a better survival than mastectomy. Okay. Now these are the points which I told. Neoadjuvant therapy helps us to know the response, in vivo assessment of the response, opportunity to adjust adjuvant treatment, downsizes breast tumor, downsizes axilla, decreases surgical morbidity. You don't have to remove a big cavity, big oncoplasty, wound problem, big axillary surgery. So morbidity comes down. Reconstruction also comes down. Where you have to put a volume replacement in the form of LD perforator flap, you can actually do a local volume displacement oncoplasty. And also it addresses the early micrometastasis. So these are the benefits which I enumerated. Now we always say that in India, we have more LABCs who are going to undergo breast conservation. False. Now in India, the breast conservation rate is somewhere around 50%, even in a government and organization where low socioeconomic strata and low middle class is being treated. And average tumor size, which used to be very close to 5, has now come down to roughly 3.6. So India also has very high breast conservation rate now. So this is the paper published by one of my breast fellow, which show a trend from 2014 to 2019. You can see that what was a breast conservation rate, which was 32%, has actually increased to 64%. Mastectomy rate, which was 67.5%, has come down to 35%. And most of the tumor now are in T2 in India, unlike LABCs. Initially, 2/3 was LABC. Now LABC has come down to about 1/3. So especially in T1, T2, the breast conservation rates are in excess of 90%. Bulky T2, they are in line of 60 to 70. And T3 also, there is a high incidence of breast conservation across hormone receptor positive, hormone negative, and ER positive. And even in India, you can see that 25% of the patients are HER2 neu positive, and breast conservation rate, even in those group, is very high. So how do we improve the breast conservation rate? Number one, neoadjuvant chemo is very safe. It fast tracks the procedure because you can evaluate what is sensitive in a given patient, and it increases the breast conservation rate, and it reduces the impact of the surgery on the axilla. Chemo sensitivity is known in vivo, and you can also explore options. Now, if you see the publication by Cortazar, you can see that whether you use neoadjuvant or adjuvant, event-free survival, overall survival, all are very good. Now, if a patient has a complete pathological response, look at the Kaplan-Meier curves. Kaplan-Meier curves is used for analysis of a survival. Forest plot is used to compare two modalities, which is advanced to shift to left, shift to the right, towards experimental drug, standard of care. So you must understand. And then Kusum curve is used to put the learning curve, cumulated curve for, Kusum curve for learning curve. So you must know where do you use what type of curves, and what is the biostatistics. We have already, I arranged a class on biostatistics, so you must know this. So the red line is a group who after neoadjuvant chemo has a complete response, and look at their survival, overall survival, event free survival. They are always better in this particular group. It is more well pronounced in HER2/neu positive group, especially if you have used a anti-HER2/neu therapy. Remember, there is an interaction between hormone positive HER2/neu. It is told that hormone positive HER2/neu positive don't respond very greatly to anti-HER2/neu therapy. Remember, anti-HER2/neu therapy helps in all the group. Hormone receptor positive or negative, as long as they are HER2/neu 2 plus with FISH positive or HER2/neu 3 plus. But the benefit of HER2/neu antitherapy is maximum in hormone receptor negative tumor. It's important to understand, because hormone receptor positive is slow growing. In the cell cycle, the chemo actually acts between G2 and M phase, and that is little slow and very long. That's why the hit happens very less, so the response is less. But nevertheless, overall survival is still good. So the rationale for NACT, what is NACT? Neoadjuvant chemotherapy means breast conservation increases. You can look at this, increases from 20 to 36% to 60%, because complete response is achieved in many of them. Now, NOVA trials showed that in a HER2/neu positive patient, if you just give chemo, the pathological response was 19%, but if you add trastuzumab, PCR rate go up to 38. Remember, PCR is 38, but the response would be as high as 50 to 60. So 19% extra benefit you gain if you add trastuzumab, anti-HER2 therapy, in advanced breast cancer before you operate. So remember this NOVA trial. Now, this is a beautiful paper which is published in Annals of Surgical Onco. Institute which tend to operate upfront and give adjuvant chemo, institute which tend to use pre-operative chemo and then operate. You can see the trend of the size of the tumor they operate. Where no pre-op chemo is used, the average size of the tumor is 5 to 6 centimeter. And where pre-op chemo is used, the average size actually drops down to very, very small percent. So neoadjuvant therapy is a good institution. So neoadjuvant therapy, if you use, the breast conservation rates are high. If you try to use only adjuvant chemo, breast conservation rates are low. So next we'll compare what is the breast conservation rate in Prisma trial after a good response. So you can look that the main factor which shifted the patient from mastectomy to BCS is the use of neoadjuvant therapy. So you must use neoadjuvant therapy liberally. Now this is a Golshang paper which showed what was the reason a surgical team told, oh sorry, I can't do breast conservation. Before giving chemo, look at this, 56% of the time they told, oh, the tumor is large for the breast. 56%. Oh, probably I can remove it with negative margin, but the cosmesis and disfigurement may be poor in 26%. So these both are the reason. If you add this, almost 92%. Now the same patients, when you give chemo, tumor being big as an excuse has dropped down from 56% to 29%. Look at this, 56 to 29%. This is very important to understand. Cosmetic outcome which we thought is poor in 26% has gone to 20%, which means close to 92% excuse for not doing breast conservation has come down only to 39%. So these are the other factor like contraindication for diffuse microcal, multicentric, you can't change by neoadjuvant chemo. They remain as it is. Big tumor shrinking and cosmetic outcome and need for a major plastic surgery like volume replacement replacement is rare. So this is the benefit you have. Now I'll concentrate on axilla. So primary breast I've addressed very well. Now axilla. Now, if a patient is not luminal A variety, remember in pure luminal A variety, pathological complete response is very, very rare to achieve, sometimes 9 to 11%, because it is a very slow growing tumor, differentiated tumor, long cell cycle, because the chemo acts between G to M phase of the cell cycle. Read it. And that doesn't come within 3 months in many cell cycle, because it is like 6 months. Chemo hits, all the chemo gets over in 3 to 5 months. And if all the cycle in the breast doesn't pass through one pass of cell cycle, they cannot be killed. That's why response is less in, luminal A. But that doesn't mean overall survival is down. That's one of the few things. Absence of able to achieve high PCR in luminal A doesn't translate to poor OS. Pathological complete response is a good predictor of overall survival in all breast cancers except luminal A. Remember, so even if luminal A, it's difficult to achieve PCR but you have a long extended 10 years, 7 to 10 years extended hormone therapy to give overall survival. So potential subsets of the breast, especially HER2 positive, if you can use neoadjuvant trastuzumab or pertuzumab, remember there is a chance of de-escalation. Now we will look at the Neosphere data. Now the Neosphere data showed that if you use a dual anti-HER2 blockade, look at this, PCR rates which are in the tune of 60% is going up beyond 70%. PCR means what? Primary tumor vanishes in the breast, also in the axilla. So no need to remove those axillary nodes if we can know their pathologically complete response is already achieved. So the difference between Neosphere and Trefina, Neosphere showed that whether it is hormone positive or negative, both achieve a benefit, even though the maximum pathological response was in hormone negative. Look at this, hormone negative achieved almost 63% complete response both in axilla. If they are hormone positive, then it drops down to 26%. So this is what even the Trefina trial showed, that FEC with this, the pathological complete response in axilla are as high as 70% in hormone negative, which means axilla can be avoided. So how do we do this? Every patient before undergoing neoadjuvant chemo should have a clipping. Remember, triple assessment, no treatment on FNAC. Never do any treatment on FNAC. This is an era of image guided core biopsy. So you do high frequency ultrasound of the axilla based on the sounds trial which I spoke last time. Classify the lymph node, suspicious, not suspicious. If suspicious, do a core biopsy. And then prove node is positive or negative. If node is negative, you know that it is N0 clinically now. So later you can do a sentinel node. If node is positive, clip the node which is positive. And also clip the primary tumor, because 30 to 60% pathological complete response happen. If you don't know where the tumor was, you don't know where to excise, go stectomy and to prove whether it is pathological complete response. So put a clip. So now initially what people worried was, if you give neoadjuvant chemo and then do sentinel node, the FNR rate. I told you last time that the ASCO is recommended to do a sentinel node, false negative rate should be less than 5% in your institution. Most of the institution has 3.5%. But if you give chemo and then you do SLNB, most of the study, including NSABP, showed the false negative rate is as high as 10%. So it is not safe. False negative rate is 10% if you give neoadjuvant chemo. But if you can clip that positive node before starting chemo, and when you do chemo and then go for SLNB in the armpit, along with SLNB, if you can remove that clip node, then the false negative rate drops down to 3.5%, same as a de novo upfront SLNB. So now this is a Cordill's trial, which is the node in the axilla which is positive is also clipped, and that is also removed. This is called as targeted axillary sentinel node dissection. So you clip the primary tumor, you also clip the axilla and remove both of them. You can either put iodine seed, or you can put a wire, or you can put a clip. So this is very, very important. So clipping at both level is important. Now there is two important issue. You don't know the type of shrinkage that happens. Is it concentric tumor shrinkage or patchy? Sometimes you have a 5 centimeter tumor, you put a clip, and after 2 chemo, the clip is eccentric because the shrinkage has happened in another way. So it is wise to clip after 1 to 2 chemo. You give a chemo, it shrinks first, By second it shrinks, then it sort of consolidates to one small marble. Then if you can clip it, it is good. But it's very difficult to coordinate. But ideal time of clipping is not before starting chemo, usually after one or two chemo before it disappears. But the problem is, if you are busy and two chemo is over, you don't clip, by third tumor will gone. So, but ideally if you want to clip, you should clip it after seeing how it is shrinking before starting the third chemo, if you can do it. So now this is what I told you. False negative rate in SLNB after chemo in node positive, which is 10 to 15%, has now come down to 1.4% if you can clip. So now the current guideline is, before starting chemo, if you can do ultrasound of the axilla, do a sound trial, suspected node core, if it is positive, clip that. And then when you give neoadjuvant chemo and operate, the axillary recurrence is less than 1%, 0.6%. I've shared all the papers I published from our center. The axillary isolated recurrence is 0.2%. Even the false negative rate is 3.5%, all of them don't recur. Because in this era we give chemo, hormone therapy and radiation to breast tangential beams go, all of them don't recur based on that stem cell concept. So then it is very, very safe now. So these are the various trials which showed that if you can clip the axilla and then go back and do targeted therapy, not required. So this is the flow chart. You can go back and read how you do downsizing. Then you clip the node, and then if you remove, and if they fill into Z11 criteria or the other criteria, ALND is always not required. So axillary lymph node dissection can be avoided in 40% of a positive axilla by giving neoadjuvant chemo. I told you 60% BCT increases breast conservation and 40% de-escalation happens. And you can see that this is very, very safe proved now. Axillary surgery after neoadjuvant chemo. If you have achieved complete response, no need to do. If you remove a clip node with SLNB, all the time you don't have to do ALND, and it's a level 2B recommendation. We know that level 2A, 2B can be practiced. Now, when you have operated after neoadjuvant chemo anti-HER2 therapy, you remove the primary tumor and the axillary node. Now, what would we do? Any patient who had a neoadjuvant treatment, never accept a report from a pathologist unless there is a RCB index. RCB quantifies residual disease following neoadjuvant treatment, which is assessed by the response in the primary tumor size, percentage of invasive versus in situ, and lymph node assessment. 3 components in RCB. So this was presented by the meta-analysis in 2019. So he is a person who really presented this. The most interesting result are what is the index score after chemo and what is its impact. Now, how do we do a RCB predictive model? It is available in the net. You can go back and read. PCR, then obviously no residual tumor. Now, if there is a residual tumor, we classify it as RCB 1, 2 and 3. RCB 1 means the score is between 0 to 1.36. It's minimal. It behaves like a PCR. RCB 2 means the score is between 1.36 to 3.28. It's moderate. RCB 3 means extensive. They didn't derive the benefit of neoadjuvant. They don't do well. You have to change the plan. You have to give second line chemo or do something. Their survival is poor. So after 2007, all the reports should have this RCB score 1.36, 3.28, more than 3.28, RCB score 1, 2, and 3. I'll tell you what is it, okay? If you go to online, there is a calculator. We call that RCB calculator. If you put the value, say for example here, primary tumor 4 into 2 centimeter, 40 into 20 millimeter. Cellular percentage you see in the tumor, 2%. Percentage of cancer cell in situ, 0. Lymph node positive now after chemo. Number, diameter of largest metastasis. Then calculate, it will give a RCB index. Stuck here in this patient, 1.271. Residual cancer burden is RCB1. So you have to, how do we assess? This is my pathologist, Dr. Sushmita has given in my patient. Look, there is a patchy area. All of them may not be the tumor. There may be a scar left. You cut into multiple serial section and take all the tumor assessment and the lymph node assessment. Look in the microscopy. See here, clipped metastatic lymph node. Can you see this? Post NACT shows sheets of phony macrophages, no evidence. Other lymph node shows reactive change. So then we put a RCB calculator. So what is the definition of PCR? There are three definitions of PCR: breast PCR, node PCR, total PCR, and German breast cancer group PCR definition. No tumor in the breast, but microscopic tumor in the axilla. It is still not PCR. That is breast PCR, but not total PCR. So B PCR, T PCR. T PCR means absence of invasive cancer both in the breast and axilla. In situ can stay, no problem. But the German PCR rate says even in situ should not be there. Remember, chemo may not remove in situ changes. That's why diffuse microcalcification all over the breast, malignant looking, cannot be downsized by neoadjuvant chemo and still remains an absolute contraindication of breast conservation, because DCIS is not an invasive diffuse microcal, that is will not go. So breast PCR can be achieved, total PCR can be achieved, in situ unlikely. But the German breast cancer group takes even absence of in situ. So you must know what is the definition of PCR. Three types of PCR: BPCR, TPCR, GBG PCR. Please read about it. This is all I can give an information in the given talk. Now remember, the PCR rates are highest if it is HER2/neu positive and you are given dual HER2/neu therapy, which is in the tune of 60 to 70%. Luminal A has the lowest PCR rate as less than 20%. And triple negative has a good PCR rate 40 to 50% of the time, but recurrence is high in the triple negative. Triple negative, if it doesn't recur in 5 years, we consider a cure. Hormone positive patients can recur as late as 7-15 years. So until 15-20 years, we can't consider them as cured. Okay. So the PCR rate is low in lobular carcinoma, and it is also low in less than 10%. Look at this. Also in luminal A. Where is the highest PCR? Our HER2/neu patient, anti-HER2/neu therapy given. Look at it, excess of 40%. So you must understand, triple negative is between 30 to 40. Remember this, 30 to 40. This is a beautiful chart to understand. Excellent. Lowest is in lobular, well differentiated tumor, luminal A, less than 10%. Lobular, well differentiated cancers, luminal A, 10%. Triple negative between 30 to 40. HER2/neu positive, if anti-HER2 therapy is used, more than 50. So remember this as a student in exam when you get a breast cancer case. So PCR, you look both primary, lymph node and in situ component. So this is our study. At my Manipal Cancer Center, my pathologist, my fellow Archa has done this. Look at the RCB score we had in our luminal A had the lowest PCR rate. Anti-HER2/neu therapy has got highest 46%. See, RCB is 0 and 9. So how much is it? 9 plus 46, 55%. 55% RCB score. Luminal A only less than 3 to 4%. So this is our group, and we found in our group those patients who achieved RCB 0-1, their survival was the best in Kaplan-Meier. Who didn't achieve RCB, who had RCB 3, worst prognosis. So this is the first study from India, which is done by my fellow Archa. She's going to present it in a BSICON Congress, which is going to happen in Hyderabad in August. So the group which took neoadjuvant dual anti-HER2 therapy has the best RCB, and they had the best survival benefit. Now, what is Catherine trial? Catherine trial showed that if it is a HER2/neu positive, you are given HER2/neu therapy with chemo, and when you operate, if it is RCB 0 and 1, you can continue same trastuzumab without compromising the overall survival. If the patient had a RCB 2 or 3 response, not very great response, instead of trastuzumab, antibody conjugate TDM1 if you replace, that's also anti-HER2/neu, instead of trastuzumab, then the survival was 11% better. This is the first trial which showed neoadjuvant treatment based on the pathological response, tailor-making adjuvant treatment has a survival benefit. So Catherine trial told anti-HER2/neu therapy, neoadjuvant chemo with anti-HER2/neu, if you have a RCB 0-1, continue same trastuzumab. If you don't have a good response, RCB 2 and 3, don't give trastuzumab, instead of TDM1 you give, then 13.3% it is better. So this is Catherine trial. Please remember this. The counterpart of this is Createx trial. Triple negative patient. If there is no good response, if you add capecitabine tablet for 6 months, survival is better. Please read about this. I'm not going to go too much. RCB01, no benefit of TDM. So currently, if you look NCCN criteria from 2020, AGO guidelines, ESMO guidelines, St. Gallen's, all of them now told level 1, category 1, if residual invasive cancer is there, RCB1, please give TDM1 for 14 cycle. All the three guidelines have changed. See this, ESMO, NCCN since 2020, AGO guidelines, St. Gallen's is recommended. That's why neoadjuvant chemo has to be given. Also, we have extend neck trial which showed that niratinib, if you add to these patients, overall survival also improves. Please read about this trial, extend neck trial. So this is something we must understand, this particular area. So now the third point, how do we reduce reoperation? Why do we operate after breast conservation? Margin has come positive. Now remember, if you see the British BMJ, in England, the re-excision rate after breast conservation is as high as 20% because availability of frozen section is very expensive in UK. So all centers don't do frozen section. You do a breast conservation and finally the margin positivity is high, 20%, and you have to go back second time. So you may lose the breast or you have to do double surgery. So pre-operative chemo reduces the need for re-excision. Look at this. 63% of the time, if you have to re-excise, it falls down to less than 35%. So re-excision or converting to mastectomy because margin is positive has fallen down from 95% to 5%. Patients who undergo neoadjuvant, 60% will achieve pathological response. Most of them shrink. So margin positivity chances come down. So second thing, local recurrence after chemo and breast conservation with no ink margin. See, we always say upfront breast conservation, what is a negative margin? Macroscopically, as a surgeon, when you remove it is 1 centimeter. But microscopically, pathologically, no ink at the margin. Even one negative cancer cell is enough. Does this apply even after neoadjuvant chemo? Should we remove what is left behind or before? This trial actually answered. People ask, no? The meta-analysis of 4,198 patients from Fitzgerald trial, Migo trial, Mori trial, and Swan trial. All of them showed excise what is left behind in breast conservation and still the breast conservation is safe. So the breast conservation new boundary is safe has been proved by this study. So you can read this, Chen in JCO 2004. So whether it is unifocal, multifocal, multicentric, no ink at the margin after chemo is still safe and the chance of recurrence is less. What are the factors which increases local recurrence in breast conservation? If you give chemo, still 2 centimeter residual tumor is there, lymphatic invasion is there, multifocal. These are the three factors. After chemo, if you are left with 2 centimeter, RCB2, lymphatic invasion, multifocal, it is possible. All of them, reoperation chance is lowest if you are given anti-HER2 highest in luminal A because shrinkage is less. So PCR is a surrogate marker in survival for all except luminal A. Remember, look at this forest plot. Luminal A you can't achieve PCR, but still they have a survival benefit. So PCR is a predictor of overall survival in all luminal B, TNBC, basal and HER2-neu, but not in luminal A. Okay, so the local recurrence is low in all of them. So what is the definition of a R0 resection after NACT? So this is a paper you must quote, Wimmers, which says no ink, no difference in local recurrence based on 1 millimeter negative margin. It is same as pre. So this is a consensus congress which happened. You can see that what is the adequate margin in the surgery, no ink on the tumor even after chemo. This is a consensus conference which is published. You can go and read in which happened in Switzerland. 77% of the expert agreed no ink even after chemo, same as upfront. Now other point. This always student asks. You are given chemo anti-HER2 therapy, tumor vanished. Mammography normal, MRI normal. So can we omit surgery? Can I just put a ultrasound probe and cryo that leftover clip area? Can I do radio frequency ablation? Can I do microwave? So this is a trial. EBCTG Lancet, published in Lancet 2017, looked. There are some patients who responded completely. Even though surgeon recommended surgery, they refused. Those group, in spite of complete clinical response, they got operated. And they all took neoadjuvant, adjuvant, chemo, RT, and surgery, everything. Now look at the difference between the survival in the patient who underwent surgical excision, who didn't undergo. It is dramatically different, 20 to 33. So 10% improved. So, there is a chance, even though there can be complete response, there is a chance there is a group of patients who recur. So, which means as of today, there is no way you can avoid a surgery in a breast cancer, solid tumor, unless you remove it. So, local recurrence is still high, even if you achieve pathological complete response, if you don't remove them. So, these are the predictive values. So, second issue, when is the right time to do surgery? After chemo. You know that in ovarian cancer, the surgery should be done as early as second week, never later than 21 days after the last neoadjuvant chemo. Every week you delay the surgery in ovarian cancer, you lose 3 months of lifetime. Delay in starting the adjuvant treatment after surgery in ovarian cancer every month compromises 3 months of lifespan delay. After neoadjuvant, the right treatment time to operate is 2 to 3 weeks. If you delay beyond that, the resistance trying grow and then the outcome alters. So now is it similar in breast cancer? This is a beautiful paper published in EJSO 2016. What is the optimal time to operate after chemo? Surgery done within 21 days, surgery done after 21 days. You can look at it. If you do surgery after 21 days, the recurrence is high. So the answer is what? The answer is within 21 days. And this is the trial you must quote in the paper which was published in St. Gallen's. So this is something which I wanted to say. This is again reiterating that if you can clip the axilla and then remove that and then remove, then the FNR rates are still low, so you can do that. So in summary, if you want to look at it, you give neoadjuvant treatment. If it is a complete response, trastuzumab to be given. If complete response is not achieved, you give TDM1 in these particular patients. So as per all the 4 guidelines which I have uploaded. Now, what is the indication for neoadjuvant treatment in a operable early breast cancer, even if breast conservation is possible? Any tumor more than 2 centimeter, if it is HER2 positive or triple negative, needs neoadjuvant treatment or node positive. Remember this. What is the current indication for neoadjuvant in a operable? Don't confuse LABC. LABC is already covered. We know LABC. All LABCs except luminal A undergoes neoadjuvant treatment. But in an operable early breast cancer, even if breast conservation is possible, tumor size more than 2 centimeter or node positive should undergo neoadjuvant treatment in this era, which is the current guideline. So, in summary, MDT based treatment. Before you operate, don't do FNA core biopsy. Do IHC4, ER, HER2 K67. If it is triple negative, also do PDL1. And if the patient fits into the HER2 BRCA, please do BRCA. You must have all this information. Just because it is operable, don't operate. Just because there is no node metastatic survey negative, don't operate. Just because at presentation breast conservation is possible, don't operate. First to do a thorough examination, ultrasound of axilla, core the node if there is a doubt, then put a clip there. If it is HER2 positive or triple negative, if the tumor is more than 2 centimeter or node positive, please send that patient for neoadjuvant treatment after clipping the primary tumor and the axillary node, and then do a breast conservation later. So this is the current guideline. So neoadjuvant therapy now is not just downsizing, but it is also increase the breast conservation rate 60%, 40% de-escalates the axilla and reduces the resurgery rate from 20% to less than 1%. So thank you very much. I would end my talk here. Hundreds of journals any new publication, and still, to assimilate for a first year student is tough. But I have tried to give all the concepts for you very well in a 3 series, so that should give you understand how to approach. Okay, now Narendra has written, sir, any evidence using trastuzumab in adjuvant in HER2 low? Now there is a new trial that has come. Initially, remember, HER2 positive means 2 plus with fish positive, 2 plus IHC or 3 plus by IHC. But now the new evidences, new trial has come in recent ASCO. Any patient he is HER2 positive. Means, see, remember, by definition, what is HER2 positive? IHC 3 plus or IHC 2 plus confirmed by fish. HER2 0 is negative, HER2 1 plus is taken negative. But now the new trial that has come, that Duraxicam, if it can be used even if it is HER2 1 plus. So it's a new trial, read it, published recently in ASCO. Standard chemo NACT for HER2 enriched. Yeah. Now remember that most of the time the chemo that is being used is 4EC. Epirubicin has less cardiotoxicity than adriamycin. People were worried. Anti-HER2 trastuzumab has cardiotoxicity, anthracycline has cardiotoxicity. If it's a left-sided behavior, later you give radiation, the coronary artery and the ventricle will get irradiated. So triple attack on the heart. Anthracycline, trastuzumab, and RT. So people used to now think that most of the non-anthracycline based regime you use. So epirubicin is less cardiotoxic than AC. Now most commonly used treatment is TCHP, docetaxel, cyclophosphamide. Okay, H is Herceptin, P is pertuzumab. TCHP, if you use dual HER2 blockade, if patient is not affordable for dual HER2 blockade, then most of the time people use 4EC, 15-day. Then they will add trastuzumab with weekly paclitaxel 12 weeks. This is the most common anthracycline based, otherwise TCHP. So this completes my thing in the chat. Let me go to the Q&A section so that we can see what are the other questions they have put there. Okay, I think I don't see any too much of the questions there. So that means everybody is very, very happy. They understood all the things what I taught. It cannot be achieved and mastered in one section, but you can actually, understand, learn it very, very easily. Okay, racist 1:1 criteria used for post-NACT assessment. As I told you that clinical CR doesn't automatically mean pathological CR. You can use clinical examination, ultrasound, memo, and MRI. Unlike the metastatic setting, or unlike the other GI and other where you want to use neoadjuvant, where you are not going to operate, then RECIST criteria helps. But here in breast, after neoadjuvant, almost close to 100% are going to get operated. So pathological assessment is better than RECIST criteria, RCB index. So that's why better to use RCB scoring, which I showed, 1.66. Why core biopsy and not FNAC of axillary node? Now primary tumor has to be core because it distinguishes invasion from DCIS. False positive, false negative doesn't happen. You don't delay surgery by FNA, not clear, second FNA, then you do incision biopsy, wrong scar, incision place, compromises the breast conservation therapy and oncoplasty and everything. So for the breast core biopsy, if there is a sizable node, you can do a core biopsy of the axillary node. If it is a small node, that is the only place where FNAC is accepted. Remember, in the breast you have a normal gland. Then you have a breast cancer, ductal carcinoma arising or lobular, similarly difficult to distinguish. But in axilla, that arises from endoderm, lymphocytic predominant. There you can't see a epithelial component. If you see epithelial component, it has to be cancer. Like there is nothing called as lateral aberrant thyroid. If you see a thyroid tissue in a lymph node, even though it doesn't look cancer, it has to be papillary CA. So FNAC in axilla is accepted. However, if you can do a core, if the need is 7 millimeter, you can do. But however, FNAC of axilla ultrasound is accepted. But clip it, so you remove it. Please guide on the neoadjuvant hormone therapy. Yes, there are two large trials which showed that if the patient is luminal A or postmenopausal, neoadjuvant prolact trial, that is neoadjuvant letrozole, if you give, it is equivalent to chemo. Luminal A variety don't respond to chemo. So neoadjuvant hormone therapy will downsize exactly same as chemo. The only difference, chemo downsizes very rapidly fast, hormone downsizes slowly. So if you use neoadjuvant hormone therapy, then if it is premenopausal lady, you can use neoadjuvant Zoladex, that is a ovarian suppression with aromatase inhibitor or tamoxifen. If it is postmenopausal, single agent letrozole. Both of them have 69% downsizing. But if you use neoadjuvant hormone therapy, you have to give it for 6 months. So both are same. Luminal A, even 1 to 2 node positive, doesn't matter, chemo don't act, you use neoadjuvant hormone therapy, either Zoladex with tamoxifen or AI or postmenopausal, but for 6 months he has to use. There are two trial, neoadjuvant hormone therapy trial, read about it, where they did a core biopsy, identified the endopredict score and Ki67. Then they, after about 1 to 2 neoadjuvant treatment, they redo, and then the Ki67 should come down. So there is a 2 neoadjuvant trial, but anyhow, this is about hormone therapy. Bottom line, luminal A, low axillary burden, neoadjuvant hormone therapy gives same response as chemo, but it has to be given for 6 months. Maximum, how many nodes can we clip? You can clip as many nodes. But if you have more than 2 node positive, then it is a high axillary burden, then it's better not do SLNB or to do a ALND. So we usually keep 2 to 3, not beyond that. Because remember, when do you clip? Node is positive, we clip it. If already 3 node are positive in axillary only before giving chemo, it's a high axillary burden. Then the false negative rate will be high, not safe to leave the axillary positive node. So 2 to 3, normally never more than 2. Schedule of response assessment. When you start neoadjuvant chemo, after every chemo, surgeon should evaluate clinically, calipers, ultrasound. But the maximum response start achieving at the second cycle. If you can't get a good response by second, there is something wrong, change the plan. By 3, it is peaks. That is when you add imaging like mammogram, ultrasound. And if you had used an MRI in a dense breast, young lady BRCA, you repeat that. So this is how is the evaluation. Clinical examination after each time, but by the end, response starts. By 3, matures. Imaging at the end of second and third ultrasound, memo. And if you have done an MRI, do MRI. Other don't misuse MRI. Schedule. So what is stem cell concept? It's too much. 8:30. I have to end it. Now remember, if you read the evolution of IOE is an international cancer center which is present in Milan, which was set up by Umberto Veronesi. He is the father of the breast conservation, the Milan group. He was also the health minister of Italy, and you know that unfortunately he is no longer there. His son is there now. So he brought this concept that when you do sentinel lymph node, what is the standard false negative rate? 3.5 to 5%, which means if you have done sentinel node, 5 out of 100 you still leave the disease node by mistake, because nothing is 100% in this world, right? So sentinel lymph node is very accurate, doesn't change the local recurrence, doesn't change the overall survival. So SLNB is level 1 evidence. It is crime in this era not to do sentinel node for a T1, T2, T3, N0 patients. Which means if you have done a sentinel node, thousands of them, for every 10 patients, 5 times you are wrong. You think sentinel node is negative, you are left the disease, which means positive axillary node is left behind in axilla. So 5% should be the local recurrence in the axilla, right? But it is absurd that the local recurrence rate is less than 1%. How is it? 5 out of 5% of the time you leave disease node in the axilla, not removed, no ALND done, yet the recurrence in axilla is less than 1%. Why? So the Umberto Veronesi brought this concept of stem cell concept. Number 1. Even though you left a positive node, the hormone therapy you give, the radiation to the breast you give, chemo you give, has an impact on these nodes, so they are sterilized. So all 5% don't recur. Second, A node positive cancer necessarily doesn't mean has a potential to metastasize outside. They say that the cancer cell which can metastasize outside is the one which has got a stem cell potential and circulating in the blood. That's why if you do a ctDNA liquid biopsy of a stage 1 stage 2 breast cancer, even though PET scan is negative, 2 to 3 5% you can find a cancer cell in the bone marrow. Still they are not an indication to give chemo. Still they don't die, patient don't die, still they are cured. Why? All the metastatic cells present in the blood, bone, outside known doesn't have a potential to form a systemic metastasis. Only a totipotent stem cell has a potential to form a systemic metastasis and death. That's why 5% of node positive still they don't metastasize outside. 2 to 3% circulating tumor cell DNA from the breast cancer still they don't die. So that is the stem cell concept proposed by Umberto Veronesi. Okay, I have to end it. I'm very sorry because this is a very exciting topic. I know it is like getting married. You go and propose your girlfriend and you want to sit and speak to her whole day because you are enjoying it. But all good things has to come to an end. As I told you, I can just stimulate you. I can give a thought process. I've given so many thought process today. What is the ideal time to operate? What is the re-excision rates? When should you do? What is PCR? What is RCB? Now go back and read because there has to be something left for you to do. So thank you very much. I hope it's very useful. I'll try to have 2 or 3 more breast series so we can complete this. Then I'll move to more of head and neck, thorax, lung, GI, rectum. And I would really want some of the students to present some cases. Any two of you, please take early breast cancer and try to present so we can have that session after the other two. Next two session, I have a top, cytopathologist of India, Dr. Shanta Madam from Tata, who is retired in Bangalore. She's going to speak on cytopathology for surgeon. Then I have applied surgical anatomy and the facial nerve of the parotid tumor, and how to do a good parotidectomy. After that, I am not yet scheduled. So two of the students, please come up with a good case. Maybe one with phylloids of the breast and another with early breast cancer. Please volunteer, put in the WhatsApp group your name. We will do a case discussion. Thank you very much, and over to you, Navneet Singh ji. Thank you for coordinating this. Navneet Singh ji, over to you.
Excellent presentation, Professor Dr. Somashekhar. Thank you very much for this presentation. And thank you very much, trainees and faculty members, for joining us.